All right, well, this is the beginning of chapter 5. This is Humerus. There are multiple lectures from this chapter, but this is the first of them. So chapter 5 in your textbook of radiographic positioning and related anatomy, the 11th edition, this begins on page 176. This image right here, where we are visualizing the shoulder girdle, this comes from page 176, figure 5.1, and this is literally, we have come all the way through so far where we have looked at the hand, we've looked at the wrist, the thumb, the forearm, the elbow, and now we're going to look at the humerus, and then after that we will look at the shoulder girdle. So the shoulder girdle is actually made up of the humerus, the scapula, and the clavicle on both sides. The humerus is the largest and longest bone of the upper limb, and in an adult it's about 1/5 of the body height. It articulates with the scapula at the shoulder joint, and that shoulder joint can be referred to as shoulder joint, scapulohumeral joint, or glenohumeral joint. As usual, there are 3 names for every single thing that I feel like we have or discuss in our field. This next image is also on 176, and this is an image of the proximal humerus. So with elbow, we looked at distal humerus. This one is the proximal humerus. And on here, all of this anatomy is important. We have the humeral head right here. And the humerus actually has 2 necks. It has an anatomic neck and a surgical neck. We also have the greater tuberosity, which is located right here, and we have the lesser tuberosity. And in between the greater and lesser tuberosity or tubercle, we have the intertubercular groove or bicipital groove. Okay, so humeral head, greater tubercle, lesser tubercle, intertubular groove or bicipital groove, surgical neck, anatomic neck up here. And then you have the deltoid tuberosity and the body or the shaft of the humerus. Okay. Now, the directly below the anatomic neck, we have the lesser tubercle, and then this one is larger, the greater tubercle, and typically on tubercles, tuberosities, that's where muscles attach. Okay, so the intertubercular groove or sulcus right here, that is the groove between the greater and lesser tubercle. Right, and the deltoid tuberosity, that is where the deltoid muscle actually attaches. So when we look at this, the lesser tubercle sits more anterior. The greater tubercle sits more posterior and lateral. Moving on, if we look at this same anatomy, but in a radiograph, then we have this right here, where you can see we've labeled the acromion process right here of the scapula. You've got the clavicle right here, and those two articulate what's called an acromioclavicular joint, or the AC joint. Here we have the coracoid process, not to be confused with the coronoid process, but we have the coracoid process on the scapula. In the on the ulna, we have the coronoid process. You've got the glenoid or the glenoid cavity right here. This is the scapula. And then you've got lesser tuberosity right here, this blue line, and greater tuberosity is this orange line. And then you've got the humeral head right here. Right here would be the anatomic neck, and then surgical neck would be down here. Okay, so when we look at the proximal humerus, all of these points are extremely important because depending on the position, when we get to shoulder, of where the greater tuberosity is in profile or the lesser, it determines the position of the humerus, which also tells you what view you're looking at. Okay, so Glenoid cavity right here, the head of the humerus sits in the glenoid cavity or glenoid fossa, and that's what actually forms your shoulder joint. When we look at the humerus, it is a long bone, which means that we have to have two images of any long bones, and we have to include the proximal and distal joint. So the proximal and distal joint on a humerus would be the shoulder and the elbow. Okay? So on humerus, if we look at imaging of the humerus, the AP humerus is actually found on page 185. I do want to point out, if you look at page 182, there are boomerang filters on that page in 521, and those boomerang filters often are used to help make the image more evenly penetrated on your radiograph. And there's examples of those on page 182 in figure 5.21. Typically, the humerus is done in the bucky because the part is thicker than 10 centimeters and your KVP is above 70 for digital, or if we were talking about film, it's above 60. Okay, so on that boomerang filter that you see on 182, it allows us to see soft tissue and bony anatomy to be demonstrated because it gives more even penetration of that area. Right, so it allows you to see the AC joint region a little bit better without burning that out. If we look at the AP humerus, again, this is on page 185. It is a long bone, so we have to include shoulder and elbow joint. And the central ray is to mid-humerus, or midway between the elbow and the shoulder. Now, this AP humerus will demonstrate any fractures or dislocations of the humerus and any pathologic processes. You're at a 40-inch SID, and ideally you are in the bucky, and you are 14 by 17 portrait. The patient can either stand, which is easier on them, or if they're not able, they can lie down, but that puts more pressure on the humerus because you've got the weight of the arm on the table, which sometimes can be uncomfortable. But if they stand, then that weight, gravity kind of helps, and it's not as uncomfortable for the patient to stand for these images. The technique on this is 75 kVp at 3 mass. And like we said, we are typically in the bucky because this part is greater than 10 centimeters and we are operating above 70, which would be required for a grid on digital imaging. Central ray is to mid-humerus, so midway between the elbow and the shoulder, so about halfway down the humerus. You can see in this particular image, which is like 5.26 on 185, they have her standing with her arm right by her side, and they're finding the midpoint between the elbow and the shoulder. I personally think it's uncomfortable to stand with your arm like that. I feel like this does a much better job because this one, the patient's not as uncomfortable if you abduct the arm away from the body slightly. It doesn't necessarily have to be this much, but that is not a crazy amount. So ideally you may have to rotate their body towards the affected side so that the shoulder and proximal humerus are in contact with the image receptor or with the wall bucky. You align the humerus with the long axis of the IR in this one, but on this it is acceptable to have it diagonal for this particular image. There are a few that the long bone is so long that it would be acceptable to put it diagonal on the IR versus straight up and down. So the hand is extended and supinate the hand or put it palm out. This is supinated so that the epicondyles are parallel to the image receptor. Okay, so you want the medial and lateral epicondyles of the humerus to be parallel and equidistant from the image receptor. And central ray, like we said, is mid-humerus. Okay, so either position is acceptable, either standing with the arm down by the side or the arm slightly abducted. 40-inch SID to the wall bucky or the table bucky, 75 kVp at 3 mass. CR is mid-humerus, and with this particular image, the epicondyles are parallel to the IR and equidistant from the IR. This shows you the patient with her supine. If she was unable to stand, then this would be acceptable. You would just then be shooting to the table bucky. Again, CR would be mid-humerus, which is midway between the elbow and the shoulder. Hand is supinated, which places the epicondyles parallel to the IR. So the epicondyles here would be parallel to the image receptor here. If done correctly, then the image would look similar to this. You can see medial and lateral epicondyle right here, and those are parallel to the image receptor. We have the entire long bone here. You've got elbow joint and shoulder joint. And on this, you should include the shoulder and elbow, I would say at least an inch beyond both joints. Okay, you can see soft tissue clearly on this. You can see trabecular patterns in the bone. Again, marker being annotated is not acceptable. I would place the marker in the light field on the wall bucky before you shot, so you can visualize the entire humerus and the greater tubercle, which is right here. I can try and highlight that for you. Let me try and highlight that. The greater tubercle is this right here. Greater tubercle is in profile when the medial and lateral epicondyles are parallel to the IR. So medial here, lateral here. Let me try and make that a little bit different color so that maybe you can see that. Greater tubercle in profile, medial condyle, lateral epicondyle parallel to the image receptor, and that is a nice AP humerus. Moving on, if we look at this image, now this is not in your book, this is one that I pulled, but this is an AP right humerus, and this would demonstrate all the anatomy that we've spoken of. So you can see the acromion process right here. This is the clavicle, so this is the AC joint. You've got the humeral head here, greater tubercle, lesser tubercle, surgical neck, anatomic neck would be right here, glenoid cavity or glenoid fossa, the shaft of the humerus, the deltoid tuberosity, and then we've got distal humerus anatomy. You've got the lateral epicondyle and the medial epicondyle. You've got the trochlea and the capitulum. And then we have the radial head, which articulates with the capitulum. And the trochlea articulates with the ulna. Remember, this is RCUT. And then this is the entire humerus. So this is another good image to make sure that you understand and can correlate where the humeral anatomy is on a radiograph. But this is not in your book. If we look at another AP left humerus, notice that the marker is placed lateral to the part, meaning to the side of the part. Now, typically I would tell you if this is a left, you would want it to the left of the part, so in here. But sometimes you can see breast tissue right here. Sometimes you might be concerned that the patient drops their arm and gets it in soft tissue. So to put it outside like this is perfectly acceptable as long as it's anatomically correct. Okay, the arm is pulled away from the body, and the medial and lateral epicondyles would be parallel and equidistant from the IR. You definitely have the joint space and some anatomy beyond, and you've got elbow joint, and then you have shoulder joint with anatomy beyond, which is excellent. We can see soft tissue on this. We can see trabecular patterns in the bone. This is a very good AP humerus. Along with the AP, on most long bones, we have two views at 90-degree angles to one another. So along with the AP, we would have the lateral humerus, okay? And these are on page 186. Now, this particular image right here goes with figure 5.31 on page 186. This image here goes with 5.29 on page 186. So if you look at the book, they show you 3 different ways to do a lateral humerus, okay? The one image that's 5.30 is on the next slide. I would tell you that either of these, along with the one that's supine, is acceptable. I do believe this one is the best because it reduces OID the most, but in field, I used to always teach you this, and in field, they tend to do this. So we've started just doing this one because it's a lot easier for you to conform sometimes to what the sites do versus doing what is the best, because sometimes the sites don't always, not that they don't promote what is best, but sometimes patient conditions don't always warrant or allow what is the best position. This would be best because it reduces OID. This one is typically what we do. So with this particular image, we're still at a 40-inch SID. Ideally, you are 14 by 17 portrait, and it is much easier on you and the patient if the patient is standing. You can do this recumbent, and I'll show you that on the next slide, but it's easier if the patient is standing. Okay, you're going to collimate from side to side on both the AP and the lateral, but typically you're not collimating from top to bottom, especially on an adult humerus. All right, so what you're going to do for a lateromedial projection, which is this right here, a lateral medial projection, you are going to place the patient's back against the image receptor. Their elbow is slightly flexed. You may have to rotate their body towards the affected side so that the humerus and shoulder come in contact with the IR. And you're going to internally rotate the arm. Notice she has the back of her hand against her thigh. So she's internally rotating her arm so that the epicondyles are now perpendicular to the IR. Okay? Epicondyles are perpendicular on the lateral humerus. They're parallel to the IR on the AP humerus. The central ray is the same mid-humerus, and you're only going to collimate from side to side. You're not going to collimate from top to bottom. All right. When you're doing this, now that we're in the bucky, you're just going to have the patient suspend respiration, meaning you would tell her, go ahead and hold still just like that. Don't breathe, don't move, beep. This dot right here is referencing that the epicondyles, the medial and lateral epicondyles, would be perpendicular to that board and that IR if it's properly positioned. Again, you would have to get the entire humerus with both the proximal and distal joints, so both shoulder and elbow joint for that particular image. The other way that you are able to do this is with the patient recumbent, and this is figure 5.30 on page 186. Okay, so she could be lying down and you're using the table bucky, and she could again internally rotate her arm so that her epicondyles become perpendicular to the IR. central ray would be mid-humerus. And if done correctly, then what that image would look like is the pictures on page 186. This particular image probably correlates, not exactly, but to 5.32 and 5.33. Honestly, the pictures in the book, if that is a right humerus, then they place the pictures backwards, meaning you can see that this is a right, and you're looking at this as if you're looking at the patient. So 5.32 and 5.33 should be flipped so that the right marker is actually on the right side of what they're showing you. Those pictures basically are backwards. Okay, you've got a 90-degree angle between the humerus and the radius and the ulna, which is good because you do want a lateral elbow. You've got the humerus in a lateral position, and then you've also included the shoulder joint with some area beyond. Okay? So you can see the humeral head here, the body or shaft of the humerus here, and then you've got medial and lateral epicondyles here, superimposed because they are perpendicular to the IR. This next image is if there is a trauma to the patient and they're unable to do what we need them to do for the lateral. This is a lateral mid and distal humerus, meaning when you tuck the IR up like that, you're not able to get the proximal portion of the humerus, but you are able to get the mid portion and the distal portion of the humerus. So that would be one way that you could achieve a portion of the lateral if the patient was not able to assume that position, meaning that there was some kind of trauma. So this is a cross-table lateral view. You can see right here, this pointer is representing that it's a horizontal beam. So you're achieving a lateral view of the distal portion of the humerus by moving the tube to be in a horizontal position and shoot across the humerus. So this is called also a cross-table lateral. When you do that, this is what your image would look like. So it looks like you did a lateral by moving the patient, but in reality, you did get a lateral image of the bones, but you did it by manipulating the beam to a horizontal beam. On this particular image, you're getting the distal 2/3 of the humerus. It is a 90-degree perspective from the AP that was done. The epicondyles are superimposed and the exposure factors are acceptable, and there is actually a right marker placed prior to exposure, which is what we would want. So this would get you the mid and distal portion of the humerus for the lateral. But then in order to capture the proximal portion of the humerus, you would have to then do, like on page 188, you would have to do what is called a transthoracic lateral humerus. Okay? A transthoracic, meaning you're going across the thorax, across the thoracic spine, and you're getting a lateral view, again, because the patient had trauma and cannot do the regular non-trauma lateral. All right, so this is the affected arm. The right arm is the affected arm in both of these images. So if she's standing, you would do it like this. If she was recumbent, you would do it like this. You raise the unaffected arm out of the way. You're at a 40-inch SID. You're still on a 14:17 portrait to the patient in both of these, and you're only collimating from side to side. In this particular image, there is something that we do that we've not done yet. That is what is called orthostatic breathing. Okay, this is called orthostatic breathing or a breathing technique. And how we do that is there is a minimum of 3 seconds set as far as exposure time. So with this one, you use a low MA and a long exposure time. So typically we want high KVP, low mass, and we want the highest possible MA station with the least amount of time. On this one, you're going to allow the patient to continue breathing through the exposure. And what that does is it blurs out the lungs and all the other anatomy so that you can focus on the humerus. So it blurs the lungs and the ribs, so the focus is more on the humerus. So you set orthostatic breathing with a low MA and a long exposure time. Okay? You place the affected arm against the IR. You raise the opposite arm and put their hand up over their head. And you're centering mid-diaphysis of the affected humerus. So you're still mid-humerus. You're just attempting to center on this one. So if elbows here and shoulders here, you're midway on this humerus over here that's injured. Central ray is perpendicular to the IR, and it's going through the mid-thorax. You set orthostatic breathing, meaning a low MA station, a long exposure time, and you tell the patient to continue to breathe in short, shallow breaths without moving their affected arm or shoulder. And what that does is it blurs out the ribs and the lungs. Okay? If done correctly, then your image should look like this. So you're going through the thorax, you're blurring out most of the lungs and the ribs. You can see them, but you're able to demonstrate this humerus, the proximal humerus, the humeral head, and the proximal shaft of the humerus far better. I mean, that's a beautiful transthoracic lateral. You can see they're labeling the anatomy. This is the unaffected clavicle. This is the superior border of the scapula. You've got the sternum here, the affected arm clavicle here, acromion process, humeral head. The border of the scapula is here, the lateral or axillary border, and then the proximal humerus. You can see thoracic spine right here, and you can make out some ribs coming around the patient, but that is a beautiful image, and this is how it would be taken. Central ray is perpendicular to the IR. This is the affected humerus. You raise the unaffected out of the way and center middle of the thorax. Ideally, you're going mid-humerus, but it's the affected humerus, and you're shooting through or transthoracic across the thoracic spine, across the thorax of the patient's body. Okay, so with that, that is a trauma view. So the mid-distal cross-table lateral is a trauma view along with this to get the proximal portion. So again, breathing technique or orthostatic breathing is a low MA station and an increased exposure time, a minimum of 3 seconds, and the patient continues to breathe throughout the exposure. All right, so that is all there is for humerus. Again, it's a long bone, so 2 views at 90-degree angles to one another. Have to include the joints at both ends of the long bone. The technique is 75 at 3 for the AP and a non-trauma lateral. If you do a transthoracic lateral, your KVP would likely be the same, but your MA, you're going to be set at a low MA station with at least a 3-second exposure time so that you can blur out the lungs and ribs when you do that orthostatic breathing. Make sure you're mindful of the anatomy with both proximal and distal humerus. If you have any questions or comments or concerns, please write them down and bring them to class. And then the next time I see you, we can clear up any of that confusion. All right, thank you so much, and I hope you have a great rest of your day.